So what happens in cirrhosis? We have portal hypertension and all manifestations associated with portal hypertension, and you have synthetic dysfunction. Because of portal hypertension, you have collaterals which lead to variceal bleeding. It can be UGI bleeding in different forms. They also have ascites and all associated complications with ascites. One thing is the pressure-related effects. The others are pressure-related effects which can result in hepatorenal syndrome. So these hepatorenal syndrome is where ascites, portal hypertension and ascites results in renal dysfunction. And this fluid can also get infected, and these are patients who develop spontaneous bacterial peritonitis. So there are several manifestations of portal hypertension that we have to deal with and we have to be aware of. And these patients also have synthetic dysfunction, which causes problems to us, especially during the perioperative period, like they have coagulopathy and jaundice. So this is a typical picture. I mean, I've seen this 10 years ago. We hardly get to see them nowadays because these patients come to medical attention quite early. You don't see the typical protuberant belly, the wasted musculature as you see here. These sarcopenic patients, the number of such sarcopenic patients is increasingly coming down over the years is what we say. We see them in a well-preserved condition because now liver transplantation has been recognized as a standard of care, well accepted as a standard of care for patients with decompensated liver disease because of good outcomes. So the patient can have varying degrees of chronic encephalopathy. Encephalopathy is a problem because this affects their daily lifestyle, the food habits, the exercising capacity and all of that. There are significant cardiovascular and circulatory changes which I'll explain in detail in the next slide. They can have hypoxia, which can be due to a variety of causes. They are prone to have effusions, pleural effusions, pericardial effusions. Ascites per se can cause a lot of restrictive effects interfering with lung expansion, and they can have varying degrees of atelectasis. There are two other distinctive pulmonary syndromes, hepatopulmonary syndrome and portopulmonary hypertension. The kidneys, as I said, they have very high susceptibility to injury with even very small insult. Even a small infection can produce acute kidney injury in these patients. These are patients with potentially full stomach at any point in their time, irrespective of the duration of fasting. Bleeding tendencies, again I'll explain them a little more in detail. Immunosuppression is because they're chronically immunosuppressed even before they come to transplant because of recurrent infections. They require recurrent hospitalizations because of the decompensations. They can develop bleeds. They can have TENS ascites or SBP. So before transplant, they've had recurrent hospital admissions and they are colonized with MDR bugs because of repeated exposure to antibiotics. And the nutritional deficiencies, as I showed you in that picture, can cause sarcopenia in these patients. They have significant amount of altered drug handling. What happens with these patients is because of the altered volume of distribution, hypoalbuminemia. So this affects the protein binding of the drugs and altered characteristics. And the way they are metabolized in the liver is also significantly reduced. These are things which we have to keep in mind before anesthetizing these patients. Pathophysiology of hemodynamic changes. This is a very important slide. I want you to pay attention to. This explains the basics of the circulatory changes which happen in patients with cirrhosis. Without understanding this, we should not venture into anesthetizing these patients. What happens with the significant portal hypertension and portosystemic shunting? A lot of vasodilators are released into the circulation. So you have significant splanchnic and arteriolar vasodilatation. This reduces your systemic vascular resistance, because of which your effective arterial blood volume, which is a central blood volume, is reduced. Arterial blood pressure is also on the lower side for all of these patients. Then the vasoconstrictor mechanisms try to compensate that. And by trying to compensate, they try to increase the cardiac output and the heart rate, but they're not able to increase your blood pressure. So there is a resultant hyperdynamic circulation in these patients with a low blood pressure, with a high heart rate, with a low central blood volume, and an increase in splanchnic blood volume. These are things which we have to keep in mind. This diagram explains how the blood volume distribution is with scintigraphic evidence. You can see that the splanchnic part in a normal patient, only 18.2% of the blood volume is distributed. But in cirrhotics, 25% of the blood volume is stagnant in the splanchnic circulation. If you try to expand the plasma volume by giving a fluid bolus, in a normal patient, we expect the cardiac output to increase, stroke volume to increase, heart rate decreases in response to an increase in cardiac output. But this might not happen in a cirrhotic patient because cardiac output might increase because they are already in the hyperdynamic point, but more of increase actually happens in the interstitial space in patients with cirrhosis. You can see the picture here in normal patients, and in cirrhotics you have both an arterial steal and a venous steal. So these are the portosystemic collaterals and the splanchnic system that is extensively dilated. You can compare the two pictures here. The central compartment is very contracted in cirrhotic patients.